Thank you, sir. Next, I invite Major Aravind Rajan for his take on Biceps Smasher Technique.
Very good afternoon to all the dignitaries on and off the stage, and special gratitudes to Dr. Ayyappan sir for giving me this opportunity to stand here and say a few words on Biceps Smasher Technique. So basically, continuing in line with the discussion so far, the indications and the requirements remains the same. So what are we looking for? We are looking for an augmentation to the in a cuff repair with a where the rotator cuff healing is in question and the rates of re-tear might be high. So in such cases, we have seen so many patches here. So continuing that, why not a patch which can be obtained from the vicinity of the surgery, which is free in availability and also has got some extra advantages over the conventional patches. So these are my references. So there were some the scaffold studies were done by Tokish et al., which showed that there were certain changes in the biology of the long head of biceps tendon when they were smashed into stamps. So there was change in the area, the tensile properties, and also the tenocyte viability. So they showed that the area could be increased at a great range to accommodate for the massive rotator cuff tears. The area to which can be expanded ranged from 25 mm in length to 15 mm width and thickness of 2 mm as less as 2 mm. Even though the tensile strength and the tensile modulus were considerably reduced as compared to the native biceps tendon, but they found that there was tenocyte viability enough to induce further tenocyte production, which helps in augmentation and recruitment of the mesenchymal stem cells, which can accelerate the healing actually. So this was the initial experiments that were done, in which initially they were butterfly slicing of the tendon was done, where the various biomechanical properties were studied, and also initially it was done using a skin measure to study the initial properties. Later on, it was found that the tenocytes derived from these long head of biceps tendon scaffolds actually expressed some soluble signals which initiated the mesenchymal cell differentiation and to make the immature tenocytes phenotype. And it was indicated by increase in certain markers like the scleraxis and collagen type 3 mRNA expression, which ultimately meant that yes, it plays a role in the healing of the rotator cuff tendon. So just briefly going to the technique as such. So yeah. So the technique initially involves the harvest of the long head of biceps tendon, which includes an intra-articular tenotomy followed by a subpectoral tenotomy is done that is to ensure that we get an adequate length of at least 4 centimeter, following which a tenodesis has been done, subpectoral tenodesis has been done, as you can see, and the harvested tendon is measured, and it's placed into a special device to make a stamp out of it. Here there is a measurement device over there which looks for the amount of tension applied, and the usual duration to which it should be done is minimum of 3 minutes, after which you will get a dimension of at least 25 mm into 5 mm with a average thickness of around 2 mm. Here we can see that with the standard medial row repair, using the passport cannula, and there is a separate graft expander is also available, which is not shown in this video, which can be used to expand the graft, fold it, pass it through the passport cannula, and then expand it intra-articularly. Once the medial row repair is done, followed by which we make sure that the sutures are made on the cuff, and then the remaining sutures can be used to fix the medial aspect of the smashed biceps. Following which we can proceed with the lateral, the transosseous equivalent lateral row repair with 2 soil locks. So what are the advantages? This specific system gives you an uniform preparation of the tendon, better structural integrity, and it is easier to insert surgically. And a latest study by Tokish et al. Showed that there is actually 93% tenocyte viability in smashed samples as compared to the 96% in the non-smashed samples, which is adequate enough to provide the initial tenocyte support which can help in biological augmentation of your cuff. Even the MRI follow-up showed that there is complete healing with no patch visible after an average of 4.5 to 6 months. So, but what are the disadvantages? One, of course, as it's also a trick in the surgery to make sure that you have adequate subacromial space so that even though the overall thickness is increased, it does not hamper your repair. Thank you.
We can have a question or two, sir.
Is double row repair is prerequisite to do this kind of patches like smasher or
Sir, there are various techniques established, but these are the popular ones in which a double row technique is used, and especially the coverage of the myocutaneous junction is more important because that's the usual place after the double row repair where the re-tear chances are higher.
Does the idea of taking the biceps tendon change if there is any MRI finding or the arthroscopic finding showing bad quality of the tendon or fraying?
Yes, sir. It is given as one of the disadvantages of this technique. Too much degenerated or fraying of the biceps tendon is usually not ideal for this technique, even though it can be used, but it's not ideal.
Thank you so much, Aravind, and thank you so much, panel.
What is the thickness you got? How thin it was?
So it was 2 mm thin, sir. Thank you, sir.